Welcome to our second of two webinars on deep brain stimulation. Last month's event was directed toward patients and their care partners who are considering having DBS surgery. Today's event focuses on patients who have already had the procedure and hopes to answer many of the questions they and their care partners have about DBS, both immediately after and well after the surgery is completed. Whether you've had or are thinking of having DBS, many of your most difficult questions about life after this surgery will be addressed here. My name's Gordon Myers, and I am a member of the UHN Movement Disorder Center's Patient Advisory Board and chair of this event. The Patient Advisory Board's mission is to advise on innovations in clinical care, education, research, and business activities, with the intent of improving patient experience, communication, and the quality of research conducted within the Movement Disorders Program at University Health Network based in Toronto. With that in mind, I'll hand you off to this evening's moderator, Heather Sherman. Thank you very much.
Thank you so much, Gord. As Gord mentioned, my name is Heather Sherman. I'm the Senior Public Affairs Advisor at the Krembil Brain Institute at the University Health Network, UHN, in Toronto, and I'm going to be your moderator this evening. In the next hour and a half, you're going to be hearing from a member of our clinical team and also from several people who have undergone DBS, as well as care partners. Following the presentations, we're going to have a lot of time for questions. Some questions have been submitted in advance, and we will also be taking live questions too. I'd like to now introduce a few members of UHN's world-class movement disorders team, which specializes in leading-edge treatment and research for movement disorders. Dr. Alfonso Fasano, who originally trained as a neurologist in Rome, joined the movement disorders team at Toronto Western in 2013. He's currently the co-director of the surgical program for movement disorders at the Krembil Brain Institute. Dr. Fasano's main areas of interest are the treatment of movement disorders with advanced technology, including DBS, and the treatment of tremor and gait disorders as well. Dr. Sunil Kalia is a neurosurgeon at Toronto Western Hospital, using DBS and other neuromodulation approaches for the surgical management of movement disorders, pain, and epilepsy. He's also a scientist with a research laboratory at the Krembil Brain Institute, and his ultimate goal in the lab is to find new ways to slow or even halt the progression of Parkinson's and other neurodegenerative disorders. Dr. Marta Statutska is a clinical neuropsychologist at Toronto Western Hospital, conducting neuropsychological assessments of individuals with Parkinson's disease and other movement disorders. These assessments can be completed before and after DBS, or to assist with differential diagnosis and also treatment planning. Dr. Matthias Zarowski is a neuropsychiatrist at Toronto Western, specializing in the treatment of mental health issues in patients with movement disorders, including Parkinson's, dystonia, and functional movement disorders. For the past 10 years, Dr. Zarowski has been involved in the assessment and treatment of patients undergoing DBS for Parkinson's. And Aaron Yates has been a speech-language pathologist for almost 15 years. Aaron is currently the discipline head for speech pathology, a role which oversees practice issues for all speech pathologists at UHN. She also works in the outpatient swallowing clinic at Toronto Western, which sees patients with swallowing disorders from across the hospital, with about a third of referrals coming from the movement disorders clinic. So before we get started, I'm just going to share with you a few quick housekeeping notes. For those of you who may not be familiar with the Zoom webinar platform, there are two ways for you to interact tonight, either through the chat function or the Q&A function at the bottom of your screen. Basically, we'd like you to use the chat function to make comments or to give feedback. But if you have a specific question to ask of one of our panelists later in the program, we ask that you please use the Q&A option. A note that this session is being recorded, so if you prefer to ask your question anonymously, you do have that option. Just please make sure to check the Ask an Anonymous Question checkbox upon submitting your question. And if you have any technical issues at all, you can direct those questions and comments to the chat, and one of our technicians will be happy to assist you. So we're now going to get things underway with a presentation by Dr. Alfonso Fasano. Over to you, Dr. Fasano.
Thank you, Heather. Thank you all for being with us tonight too. The first event was a great success, and I'm sure this will be equally or even more successful. I'm sure you'll see my presentations. presentation. I just want to say a few words to just set the stage so that we get into the topic we're going to discuss tonight, which is what happens after deep brain stimulation is done. The first event was focused on the pre-operative part of the journey. We discussed referral, assessment, and surgery. And tonight we're going to talk about what happens afterwards. And in this very simple schematic of the DBS flow, as you see, the topic will be anything afterwards. It's not just about programming or about battery replacement. Actually, many more things happen in the life of people receiving deep brain stimulation, of course. Programming is a complex exercise we need to do. It's something that takes time. For Parkinson's disease, it's once a week for a month and a half. This is just to show how complex things can be. We use softwares that can help us identify the best settings, but it's basically a trial and error process that takes time, and sometimes even more than 6 months. Together with this, we reduce medications whenever possible. We don't do this at first for many reasons, but rest assured that if we can, we'll certainly try to reduce medications. This is particularly relevant to Parkinson's disease, but we also do deep brain stimulation for dystonia, for tremor. But for dystonia and tremor, programming is a little different. There's still some time to wait, but the appointments are not necessarily so frequent because it might take longer for symptoms to improve in case of dystonia, or for tremor, usually the improvement is very fast. So usually we see the patient and then we'll see the patient one more time a month later. So programming in tremor is easier. This is just to emphasize something that we should be talking about, which is if deep brain stimulation changes the disease itself. Deep brain stimulation, as we discussed in length, is a symptomatic therapy, meaning that we only go after the symptoms. We don't change the disease, unfortunately. Deep brain stimulation is not a cure. And so if your disease is meant to progress, unfortunately, with time, the disease will progress. However, people argue that because of deep brain stimulation, for example, you might have more chances to travel, to move, to reduce the medications, and in turn, particularly the exercise, can change your long-term outcome because you're going to help yourself. So DBS gives you the opportunity to help yourself with a better lifestyle, for instance. How do we know that? Well, there are studies showing that actually deep brain stimulation, whenever needed, can increase the survival in people with Parkinson's disease. This is what you see here on your left. These are patients that needed deep brain stimulation for Parkinson's. So it's not the general population of Parkinson's patients. Those are patients with Parkinson's needing deep brain stimulation. But some of them, the green line here, they refused surgery for a number of reasons, mainly because they were afraid of the operation. And this study shows that people who refused surgery over time died more often than people who didn't refuse and underwent surgery. So this is just one study, of course, but this seems to indicate that the survival actually increases when DBS is performed. But at the same time, I want you to pay attention to this line here on your right, which is looking at the quality of life in a variety of studies. This is a meta-analysis, meaning that it's a summary of all the publications done, and quality of life improves. But as you see, unfortunately, 5 years after surgery, quality of life reaches the level of that it was before surgery. Indicating that unfortunately disease progresses. So on the one hand, I'm saying that the quantity of life increases, but unfortunately the quality of life might not necessarily get better over time because the disease, unfortunately, if it's meant to progress, will still progress. This is my last slide. Before talking about the next steps, I really want to thank you all for being with us tonight. And importantly, the Patient Advisory Board was put together a great program, and it's been a fantastic experience for me to work with them over the past years. And I'm sure great things are ahead, and we'll do many more things. And among the many things we can do, There is certainly the idea now to create a sort of a virtual or even person platform for people to talk about their experience. We realized many years ago that people receiving deep brain stimulation need to talk to other patients, need to talk to other family members. There is the need to create a support group. And unfortunately, this wasn't possible in the past for a number of reasons. And I really hope that this is the beginning of a tradition that every once in a while we get together, and Zoom is a great platform in this regard, to talk about what's happening to all of us, to share our problems, our successes, and all together grow as a team. And I always say that patients are actually part of the team. It's not just the doctors, the teams, and then the patient as an object. Patient is part of the process, and we want patients involved, and with their help, we can do better. You see here also the logo of Parkinson's Canada. Parkinson's Canada has been a great partner over the years. And my hope is that with time we'll establish a even greater partnership with perhaps their help in putting together this support group that I was telling you about, so that we are not just talking to patients referred to Toronto Western. We don't want to do this just for Torontonian or for people in our hospital. Our goal is to really improve the care everywhere in the country, but actually I would say everywhere worldwide. And with this, Heather, back to you. Thanks.
Thank you very much, Dr. Fasano. A lot of great information there and a lot of great ideas too. I'd like to now turn things over to Ron Prosserman and Ann Freeman to give their perspectives as patients who have gone through DBS. We'll begin with Ron, who had his DBS procedure back in 2016. Ron?
Hi, everyone. I hope all is awesome. My name is Ron Prosserman, and I've had Parkinson's for over 20 years. I feel so lucky and truly blessed with my life. I have 5 loving and supportive kids, wonderful grandchildren who give me pure joy, lifelong friends, devoted brothers, a joyful dog called Cuddles in the other room, and my wife, Catherine, who is truly my soulmate and is beautiful inside and outside, and who has been with me through all the ups and downs of having this lifelong illness called Parkinson's. Family is not an important thing, it's everything. That was a quote I got from Michael J. Fox. I also have an absolutely incredible support network of doctors, physiotherapists, caregivers, and trainers. Sorry. I am truly thankful to them for being there for me throughout my Parkinson's journey. I was given my life back in 2016 when I had DBS brain surgery at Toronto Western Hospital. I was so happy and excited to have the surgery. If any of you are lucky enough and have the privilege of qualifying for DBS surgery, I highly, highly recommend you do it. After the surgery, I felt so excited and alive again. And even though there were a few complications, there were many positive, life-changing things, which I will share with everyone today. As I'm sure you can tell, I'm a positive person and look at my life as the glass being half full instead of half empty. I still struggle with anxiety, which is an ongoing battle that I'm working on, but I'm winning. Thank you, Dr. Zarowski. Sorry. I would like to share with you two of my most challenging experiences after my DBS surgery. This happens to 1 out of 1,000 patients. My wires were contaminated, so I was put on an antibiotic and probiotic for life. We'll have to see an infectious, and I get the privilege of seeing an infectious disease doctor to check in once a year. The other was the most serious situation regarding my DBS battery. When last December, during the pandemic and the day before Christmas, my battery stopped working completely and I almost died. I was completely frozen, couldn't move, and I had extreme difficulty swallowing or talking for 3 days. Wow. I was thinking at that time, this is what I would have been like without the DBS surgery. I saw love, kindness, and compassion from all of our heroes on the front line. I kept saying to myself, and this is what I took from Davis Finney, another, you don't know how strong you are when being strong is the only choice you have. Davis Finney another place. A very special thank you to Dr. Pisano, who was in Italy at the time and managed my situation from Italy. I'm sorry. I wrote it down this time. I wasn't going to do this again. From Italy, and the incredible, caring, loving nurses, frontline workers, and very kind and skilled surgeons for saving my life. I know there are too many positives to list after my DBS surgery, but here are just a few. Reducing my Parkinson's meds by 80 to 85%, and all the side effects that come with the reduction in meds. I sleep wonderfully now. It's improved movement and stiffness so much better. No pain, improved focus and alert. And most important is my mood's better and so much more. I'm almost done. Life is not perfect, but I feel passionate and alive and excited every day. Sorry, this Christmas I feel so happy. Sorry, okay, I'm gonna read it properly. This Christmas I feel so happy and at peace again, surrounded by my family and friends, who I'm even more grateful for and appreciate now even more than ever. I'm truly hopeful and happy again. I know everyone has a different story to share. And I genuinely hope that my story helps someone listening in a small way. Stay positive, test negative, and please, please check your battery if you have the surgery. Anyway, thank you. That was it. Sorry if I cried. It gets emotional. I'm happy even though I cried. Okay. Thank you.
Thank you, Ron. Thank you so much for sharing your personal story. I know that wasn't easy for you. And thank you also to Brandy in the chat for your words of encouragement to Ron, because it takes a village, right? So it's really important for you to share your story, Ron. I'd like to now introduce Anne Freeman, who was diagnosed with early onset Parkinson's about 11 years ago, and she also had DBS surgery. Anne?
Good evening, everybody. So I think it's impossible not to have overly high hopes for DBS, no matter how much they tell you, how much you know that it can't fix everything. I think everyone hopes that somehow it magically will. My neurologist at the time I was considering it said that having it done relatively early was wise before you pack up and become a couch potato. Her other proposal was an abdominal levodopa pump, which would mean no more swimming or showers, not something I could get very excited about. So I went for the brain surgery route. Once I had been declared an ideal candidate, the long wait started, and I found it hard to think about anything else. I had taken the leap and said yes, and I just wanted to get on with it. In my case, the length of time between when I first asked to be considered for DBS and when I actually had the surgery was about 20 months. And although I'm a bit embarrassed to admit it, I spent an awful lot of that time expecting the phone to ring any minute with news. Finally, in November 2017, I had my first DBS surgery. It was a bilateral SDN, and it was brutal, I have to say. It started with a wrestling match, getting the stereotactic frame onto my head, and then getting me and it onto the CT scanner, which left me in total misery. And then there were about 5 more hours of that misery before the operation actually began. I'll spare you all the details, but I came out of it with an annoying non-stop dyskinesia in my left leg, so my left leg was dancing all the time. Programming started in January. This was another phase which seemed very endless. Every time I went off meds and the settings were adjusted, then when I went back on the meds, everything went haywire. We tried and kept on trying until I was worn right out and I lost my optimism. In August of 2018, I had the C.E.T.S, which is the one where they turn off all the stimulation, off the medications, on, off, every combination. And what I had suspected to be true proved to be true. That was, I was worse off with the DBS on than I was with it turned off. That was when Dr. Fasano took me on as a patient. I had a miraculous, wonderful month soon afterwards. I went on a trip to Europe with my daughter. We had an absolute blast in London and Copenhagen. It was a great experience of my life. When I came back, things kind of fell apart. We started trying to lower the medication, and that was not going to happen. I'm still on just as much med as I was before the surgery. And I couldn't find that sweet spot that I had been in before. It was just totally gone. So that was a very tough time. We kept adjusting for months until my brain got so exhausted that I literally could not tell whether the stimulation was going up or down. I wasn't only worn out in that sense, I was becoming very depressed to the point of thinking about suicide every day. So things got very bleak. And at that point, Dr. Zorowski became the lead doctor in my care and was literally a lifesaver. The strategy had to move away from minimizing my Parkinson's symptoms to improving my mood and well-being. Towards the end of the year, Dr. Fasano proposed another round of DBS. I thought he must be joking, really. I really did. I thought he was pulling my dancing leg. How could something that didn't work the first time be better if we did it all over again? But after a lot of very difficult consideration, I said yes, which says a lot about Dr. Fasano. So in the spring of 2019, I had bilateral surgery again. This time the target was the GPI. Because I had a long list of squeaky wheel complaints about aspects of the first surgery, the team was super, super nice to me, which I hugely appreciated. But the actual surgery was harder than the first time, I have to admit. They said that the bone in my skull had grown back in the boreholes, so it was like a child's skull. They had to do a lot of drilling, many different sizes of drill bits, lots of noise, lots of drugs afterwards, but I thought they did a great job. Then it was back to more programming and more. My life was ruled by DBS, and I think that's one of its flaws. I couldn't really focus on other treatment options like exercise or physical therapy or diet or other modalities, which might help me because I was in a constant state of trying to adjust to new settings. DBS can really make you feel you have all your eggs in one basket. And when it doesn't work out, it's very tough psychologically. Having two systems to coordinate was much more complicated as well. And meanwhile, I was developing other issues like freezing and falling. During this time, I made a book of images paired with free-form poetry about my experiences. I called it the Book of Exceptions. Can you pull up the slide, please, Christian? Book of Exceptions was the nickname that Dr. Fasano gave to me. Can you see the slides, everybody? So there's the cover. So the cover is called 70 Appointments because at the time I made it, that was how many appointments I'd had related to Parkinson's and DBS, sorry, related to DBS specifically. I haven't counted lately because I've lost track. I'd like to share one image on text here with you, which those of you who have trouble with falls may relate to. The text is very short and I'll read it to you. It's called Blame. Blame slippery leaves and the unannounced hose. Blame escalator, laundry basket, leaping dog. Blame the paving stone out of place, the sculpture tipping me over just for looking. The early call I couldn't catch. Try but fail not to blame myself. Putting my energy into making art after a long time without that was really good medicine for me, even though my DBS settings were still not settled. The book was also a kind of coming out because I had been very private about having Parkinson's. It took me a long time to accept being identified as unwell or disabled. This summer, when it became firmly established that no setting made a significant difference to how much I freeze or how often I fall, I decided to turn off the STM. My voice is a bit better without it, although it's still very quiet and not always clear, and I feel more like myself, I have to say. I no longer think about DBS all the time or expect it to solve all my problems. I've shifted my focus to figuring out how best to live the life I want to live with the complications Parkinson's adds to it. I have work which matters to me, friends and family who care how I'm doing, and I'm very glad I'm still here. I would like to share one more image in closing. If you can bring up another slide, please. This is not from my book, but it's from the contemporary philosopher Alain de Botton. I copied it in this way when I was able to control my handwriting some of the time, but not others. I think it expresses how much importance there is in the way doctors communicate with us as patients. I'll read it because you probably can't read it on the slide. The difference between hope and despair is a different way of telling stories from the same facts. If you're curious to see more of my book and other work I've done, please visit my website or send me a note. Last slide, please. Thank you very much for listening, and I wish you all very well. Good night. Thanks.
Thank you very much, Anne, for sharing your perspective and for sharing your poetry. It's absolutely beautiful. A lot to be proud of. Joining us next is Annetta Stetcher, whose son Ben was diagnosed with Parkinson's at the age of 29. Annette is here to share her perspective as a care partner and as a mom. Annetta?
Oh, Annetta, if you don't mind just unmuting your microphone, we can't hear you.
It had to happen once, right, everybody?
Of course it had to happen. Thank you. Can you hear me now? Okay. In 1986, Gabriel Garcia Marquez published a book entitled Love in the Time of Cholera, a story about love, aging, and death in times of health adversity, in times of a cholera pandemic. I feel our family, in a way, is in the process of acting out our own story of Parkinson's and DBS in the time of COVID. Hi, my name is Annetta, and I'm a parent of a 37-year-old patient who at 29, as Heather said, was diagnosed with Parkinson's disease and who has recently undergone DBS surgery. The surgery took place in early June, probably the 1st and the 3rd of June or the 4th of June at Toronto Western Hospital. And this was really the hardest time of my life. We couldn't be at the hospital. We couldn't do anything to see him. And thanks to Dr. Kalia, who really kept me sane for those few days. The recovery from the surgery has been unremarkable. In fact, although I think Ben has a different story of it, but that's the child that's talking. The life just before surgery was really very limited, not just by COVID, but by the symptoms, and was limiting not only for him, but for the entire family. It was hard to see him, to see a man in the prime of his life, not be able to use his body, his mind maybe yes, but his body the way he should. So we all kind of looked forward to the surgery with a lot of anticipation and a lot of hopes for a better outcome for him. What sustained us during that time, just prior to the surgery and probably ever since, has been the unbelievable support and help that our immediate family, our nucleus family, has from our extended family and from our friends. They have been really a lifeline for all of us. Shortly after programming started, we saw what Ben had felt right after the surgery, and that is an amazing recovery from the symptoms that he's had pre-surgery. We saw him being able to do a lot of things that he hasn't been able to do before. I still have tears in my eyes when I think about the day when he told me, "Mom, can I take your car for a drive?" I think it's been 2 years, almost to a day, that he hasn't used a car, hasn't driven a car. He didn't feel safe for himself or for others on the road, and felt that it was the most responsible thing for him to do, to hang up his driver's license and the car keys. So even though I knew that once he starts and it is successful, I can say goodbye to the car, I was really excited for him, because that was a stage in his recovery that we were all looking forward to. His outlook on life had changed right after the surgery. He saw opportunities ahead of him, and so did we, in terms of his physical well-being and his abilities to look after himself. However, shortly after the programming, as his physical well-being was improving, we saw some stuff that we were really probably not prepared for. Ben has always been a very curious child and a young person. He was, in a healthy way, ready to take a lot of challenges and take a lot of risks. Some of it has been borderline, but nothing to the extreme at the time. These characteristics served him really well in the past. Once the effects of surgery and programming started setting in, what we saw was very alarming to us. We saw a young man almost at a point of mania. His decision-making process, the stuff that he was doing, the self-centeredness that he was exhibiting, the selfishness almost, was really something that we have not experienced before to the same degree. And it's probably put to the greatest test the relationship that we've had with him up until that point. Because we've always had to be mindful that our role as the partner caregiver is very different. We're still the parents, we're still mom and dad, and needing to sort of be mindful that he's 37 years old and not a 5-year-old when he's behaving like a 5-year-old, really challenged all of us to kind of step back sometimes and say, okay, you've got to learn how to do it. It's almost reminded me of those first months when he started riding a bike. At some point you had to let go Yeah, you've got to have some scraped knees, and that's the only way you learn. It would have been helpful at the time to have some, to have more services for both him and for ourselves, probably. For him, what we have found, what was missing for him was physical therapy, occupational therapy, and speech and language. Those three pieces would have been very helpful to him, and I still, to a degree, they still are, because his body, although in much better shape right now, the upper and lower body are still struggling to coordinate. His speech is still at times running ahead of his brain, probably, and his fine motor skills are still lacking. But I think the biggest issue was for us that we were not really all that prepared for the changes in personality, which have since subsided. And I keep thinking about in the first session that we had for the folks who were considering DBS, Dr. Żurawski had said that following DBS, there is a higher percentage of people whose family relationships fall apart. I can see how that happens. And I'm thinking, where, I know COVID had its own dynamics, but where in that process was some warning signs to us, to him as well. And it would have been very helpful if we had an opportunity to sit down with somebody, and Ben and us, and prepare for those eventualities. It would have been helpful even afterwards to have a few sessions, probably. Again, I consider myself exceptionally lucky with the family that we have, with friends that we have, and with my own background as a social worker, as a therapist, as a child protection worker, and all the other stuff that I did, I had been able to move back into those roles sometimes on my own to kind of figure it out. But I really would be advocating that we as a community look at some additional services for folks with DBS surgeries. That's, as I mentioned, things have turned around for Ben. He's far more stable right now. He is actually dreaming about stuff. He has plans, or is in the process of making plans. We're now adjusting to becoming parents of adult young man who is independent. Letting go is not an easy process, but we've done it once before, and I'm pretty sure that we will be successfully again, and be there. But we also are very mindful of the fact that this role of a caregiver can become a necessity at any point in the future. So my last point, I wanted to really thank Dr. Fasano and the clinic for making this possible for him. I want to thank again to Dr. Kalia. You made my life much easier during those first few days during surgery. It really allowed me to kind of relax and really think about the next steps. So that's our story. I know it's a short story. We've only been on this journey for 6 months, but we've been on the Parkinson's journey for 8 years. And so thank you for the opportunity to speak. Don't know that I can add anymore.
Thank you very much, Annetta. Knowing Ben personally, I can see now where he gets his strength and his passion for advocacy. So thank you for sharing your story. And as Mary says in the chat, these personal stories are incredibly inspiring and powerful. And so that's why it's so important for all of you to share today. And we're so grateful that you have. We are not done. We are now going to be starting our Q&A session. So a quick reminder to everyone that if you have questions, please put them in the Q&A tab at the bottom of the screen. Save the chat for comments that you have on the speakers. And if you'd like to ask your question anonymously, just make sure to check the Ask an Anonymous Question tab before you submit it. Some of our questions were submitted in advance, and so we're going to tackle those first, but we have a lot of time also for questions that are being asked live, and I can see that we've got a lot of them to get to as well. Many of the questions that we've already received have been grouped by theme in order to eliminate any repetition and to be able to address as many questions and themes as possible. So if you don't hear your question asked specifically, but you do hear a similar one, that's why, and we're going to take the same approach for the live questions as well. So one last reminder to our panelists to please feel free to jump in with your thoughts as we go, even if the question is initially addressed to someone else. What we're hoping for tonight is a dynamic and an interactive discussion. So we're going to begin with a question sort of aligned to what a lot of Annetta was speaking about, and that's allied health supports. And the first question that came in was, what kind of allied health supports such as physiotherapists, speech therapists, occupational therapists, psychologists, and social workers are available for DBS patients and their families, both after surgery and also through the years? So Dr. Fasano, do you want to start us off here?
Yeah, sure. Happy to start with the most difficult questions. I mean, because this is a frustrating part for me. Clearly, you just heard how important these professional figures are for our patients. And unfortunately, not everything can be funded. There are a large part of what we do that need additional funding. And we are first very lucky to work with Erin for the swallowing part, but our clinic still misses the contribution of other people, particularly social worker. We have no social worker at the moment, and we rely on family doctor, what we can do, but we are not trained, so we're not good at it. And nurse practitioner are helping. But certainly that's something that needs to be better addressed. Same for physiotherapy or occupational therapy. We are facing a big problem with coverage. Physiotherapy is so important for Parkinson's disease and in general for people with neurological problems, yet it's not funded. So if you have a fracture and you go for surgery, you have funded physiotherapy, so it's covered. If you have a stroke, you have a covered physiotherapy. But for some reason, if you have deep brain stimulation, you don't have physiotherapy covered. And sometimes I'm embarrassed to tell patients, look, this is needed, but you need to pay out of pocket in case you don't have an insurance. I've been practicing in different countries, and I still believe that the Canadian health system is the best that I've been practicing in because it's heavily funded, it's public. But there are areas needing improvement. One of them is coverage for physiotherapy. So right this moment, thanks to the donation of a very generous donor, we are able to run a trial. We're trying to prove that deep brain stimulation and physiotherapy is superior to deep brain stimulation alone, which is the standard of care at this moment. And the example I always make is that it's like learning to drive a new body, a new car. So after deep brain stimulation, many patients move better, but actually they fall more because they don't know how to even deal with their improvement. And physiotherapy is very important, and so is speech therapy, because speech is very often affected by stimulation itself. And I can go on and on. The short answer is that we are very far from an optimal care that we think of. We're often embarrassed to tell our patients, look, we don't have anything to offer. And we need to do better. Part of what we're doing tonight is to raise the public opinion and to let people see that we need help. And hopefully one day, I'm sure it will happen, but we're still far from the ideal care that we like to provide our patients.
Annetta, I'm not sure if you want to weigh in. If you can take yourself off mute, just based on what you were talking about earlier. Do you agree, or what are some of the extra supports based on what you were talking about and based on your own background as a social worker that you think could be helpful?
Well, I think definitely having somebody who, so there's two pieces to it. One is what Dr. Fasano was saying, the center doesn't have those services because there's no budget for it. There's no funding for available for it. But if we could even have people who are in the community, even if we have to pay some of it, maybe it's covered by some insurances, maybe however it is covered, if there are people in the that there should be some people in the community, professionals in the community who can provide, who are knowledgeable in the movement disorders and in DBS enough so that they can actually be helpful to the patients. So via referral, whether it is from the clinic or from the physician, or by having just phone numbers and say, this is what I need. But I think it's important that these people have an understanding of who the client is and what their lived experience was. I can tell you from our point of view, we're very lucky. I consider myself exceptionally lucky, and our family. We have a pool in the home, and prior to DBS last year, the pool was the place where Ben really felt like his body was working with him. When he first entered the pool this time after DBS, and it was probably around mid-September, end of September, when he got the okay to go ahead. I very quickly noted he loves the pool. He likes to be there. Our grandchildren are there with him. They're jumping. He can't move in it. And I didn't understand what was going on. And it was at that point where I kind of pulled him aside. I said, you can't even make the width of the pool, let alone the length of the pool. What's going on? And he said, it's either that I only kick with my legs or that I only move with my hands. The body wasn't working. That's what I was saying, you know, his upper body and lower body wasn't working together. That kind of understanding of where this is coming from, just picking up a phone call to a physiotherapist would not have been helpful, because they wouldn't know what he's talking about. So that's what I'm saying, that what's needed is, yes, it would be wonderful if it had happened in a clinic, but if it can't happen in a clinic, then let's come together with some names of people, some resources that know enough about what's going on to be able to be useful to folks following DBS. As for the social work services, I could spend the next year talking about it, but I won't. You all guys know. You all know what's needed. Right? You need
Thank
someone
you.
to sort of hold people's hands.
Thank you, Annetta. The next question is related. Non-motor symptoms such as
Heather,
anxiety. Oh, yes, sorry.
If I may interrupt, because I thought Dr.
Of course.
Fasano was a little too humble. And there are some people missing from our panel today, and that's actually the nurses that we have, who are really the first line for everybody after they have DBS. I mean, they field a lot of these kinds of phone calls. They are really there to support, especially in the first few months when all these changes are happening. And without them, we'd be nowhere, really, because they do a lot of this kind of support work to get people through those initial hurdles, especially. So I'd really want to sort of shout out to them and recognize that they make this all happen.
Thank you. I should have made it clear. I didn't mention nurse practitioners. At the moment, we have 2 nurse practitioners, and we clearly need more. So absolutely, you're right. My point is just their job is not to be social workers, right? This is what I'm saying. And actually, this also gives me the opportunity to thank you, Matthews, because as a psychiatrist, sometimes, actually more often, especially lately with COVID, we need your help. Sometimes I feel I need your help as as one of your patients. So this is certainly important. We're just talking about the non-MDs, and talking about non-MDs, also Marta, but also Melanie, who are from neuropsychology. They're also very instrumental in keeping track of the cognitive aspects of the disease over time, also not just before surgery. So simply because I didn't mention each of you, I'm extremely grateful. I was just focusing on the areas of criticity where we need to do better. Obviously, I'm assuming that what you're doing is perfect already as it is. But I agree with you. It's an important clarification to make.
Absolutely. And it just points to the importance of the interdisciplinary team, not only on the on the clinical and the physician side, but also the support team and the allied health team. The non-motor symptoms such as anxiety, depression, and apathy that come with Parkinson's can at times be more debilitating, than the motor symptoms that DBS treats. So what do we do to treat the psychosocial impacts, which jumps off from our previous question? Matthias, do you want to start us off with that one?
It's a great question because very much Parkinson's has a whole series of symptoms, and really the DBS is meant to target the movement ones. I mean, that's ideally what we try and do, and yet changing medications can have impact on some of these other symptoms. So one of the things that we try and do is initially see, like when we screen, who's at risk, who's at lesser risk, but have these conversations so that the person who's undergoing the surgery, they're not there alone. There are other people with them. And that's another thing that's so important, that I think every one of the individuals who has undergone DBS or has a family member with DBS has recognized today that family is so very important, or support network is so very important to identify if we are missing something as we focus on movement and change medications, because these medications can cause manic-like behavior. These medications withdrawal can cause apathy-like behavior. So these are the things we need to keep an eye on as the stimulators are turned on and medications changed.
Thank you very much. Anne, did you want to add anything based on your experience?
Well, I found medications were very effective in my case, but Dr. Zarowski was also a wonderful caregiver in that sense of being sensitive to what was really going on and making the adjustments. And Dr. Fasano was really great in terms of turning over that leadership to Dr. Zarowski, because they make a great team, but everybody has their strengths, but we need them to work together for sure. Makes a big difference. It can be hard to choose in tough trade-offs, because like at some points with the stimulation settings, I was asked to be like, I was kind of trying to choose between pain and misery, emotional misery. So sometimes it was an impossible trade. You could speak or you could move better. You could do one thing or not another, but that's really tough when you're a patient to choose one bad thing over another or one lesser evil sort of thing. But I feel past that now.
Absolutely. Well, the next question has to do with some of the downsides. So why do DBS patients lose their voice, for example? What happens to vocal cords, facial muscles, and swallowing ability after DBS, and what can be done about it? Who would like to take that one? Maybe Erin?
Yeah, I'd be happy to talk about that a little bit. So, I mean, of course, not everyone experiences deterioration in speech and swallowing post-DBS, but certainly a subset of people do experience it. And it, as far as I'm aware, it's not, but maybe Dr. Fasano can comment more. But I don't think it's always easy to predict who will have difficulty after DBS. But I think there is some literature to suggest that some people who have some speech and swallowing problems before surgery may be at higher risk of even further changes after surgery. And then, of course, the disease progresses along anyway. So, in terms of speech, there can be a lot of different things that change. There can be a deterioration in articulation, so the sounds of your speech are less clear. The vocal cords don't close fully, which can affect the sound of your voice, but also the safety of your swallowing. And your lungs too. When lungs were mentioned, there can sometimes be some more rigidity, and so it can be hard to take a really big deep breath to make your voice project and to make a big strong cough. So lots of these things can be affected, and I think because all of these body systems can be affected, I think there are a lot of speech therapy techniques that can help, and I think there is some evidence too, in some cases, that like lower frequency stimulation can help, but I don't think that's true for everyone. And sometimes it can be a bit of a trade-off. So there's, and a lot of the speech therapy techniques, I'm sure it's similar with physio, they require a lot of effort on the part of the patient, but they really can help a lot to maintain and protect some of these functions. So I think it can be an important piece for sure.
Absolutely. Thank you very much. Dr. Kalia, maybe you can take this next one. Why do some DBS patients have worse balance after surgery? what is the trade-off between positive effects versus negative effects over time on the risk and the fear of falls and fractures?
Oh, that's a great question. Very complex question, actually. So there's a theme that I think that's emerging is the balance between risk and benefit. And so, with respect to balance, as everybody and most people here would know, Parkinson's affects balance. And our ability to predict before surgery whether someone's balance is going to be better, worse, or the same is actually quite difficult because there are so many different variables at play. So statistically, what we're trying to assess as a team, we discuss balance, and Dr. Fasano and the neurology team do careful examinations on and off medications. And a patient's balance before surgery is a point of discussion. It helps us decide which target might be better to select for DBS. Once the surgery is done, the surgery itself can temporarily or even permanently, in rare cases, affect someone's balance or leg function in a negative way. It's the exception, not the rule. But certainly stimulation, even with the electrodes in the correct location, can impact someone's balance. And that can be very challenging for patients with DBS, because a lot of people, this is a quality of life intervention. They're going for it because they want a better quality of life. And of course, balance, your ability to play golf or go do activities is very important to you. And if the stimulation, and you heard some of the patient stories, if with the stimulation later, if you're put in a situation where you have to choose with turning the stimulation down and some other things get worse, but your balance gets better, and vice versa, can be challenging. The team has expertise in trying to fine tune this, but we're also competing against the progression of the disease as well. So as Dr. Fasano showed a slide, each year that goes by, so we have so many variables: the surgery itself, the stimulation parameters, on-target side effects at the correct location, off-target side effects, and progression of the disease all factor into balance and the fine-tuning required around that. So it is it's very similar to speech and swallowing. And you've heard examples of patient stories where with activities that people used to like to do, there's a disappointing result in some of those activities where you can't do them anymore because it's not safe, or you need help to kind of recalibrate expectations in those activities. So that's how I'd answer that particular question.
Okay, thank you very much. Marta, how about you try to take this next one? Having your DBS turned off can be extremely traumatic, whether from a dead battery or by design to complete a medical procedure. So what do we do to better prepare patients for such an event and also the aftermath?
Oh, I'm not sure that I am the best person to answer that question because I don't see people on a regular basis. I know the team asks people to monitor their batteries very closely. I know Ron had a very upsetting experience that he spoke about. So maybe he has some points about what he could have done differently.
Sure. Ron?
First of all, I take responsibility for, I'm partly COVID also. So I think it's a mixture of everything. I think, but I do take responsibility for not properly checking. I can tell you one thing is I was frozen for 3 days. I couldn't move, couldn't swallow. And I kept saying to myself, imagine if I didn't have the DBS surgery. So I just want everyone to know there's pros and cons to everything. And I just, if you qualify for the surgery by people you have confidence with, then I think don't do it because you're scared. Don't, like, if you don't qualify, it's not for everyone. If you qualify and you trust the doctors, the way I trust our doctors here, it's silly not to do this. Sorry, I don't mean to be so preachy. I apologize.
Sorry, was somebody else jumping in
Yeah,
there?
can I add something on the topic of checking checking the battery, which is important, as you heard. I want to just emphasize 2 points. The first one is that I don't want people to think that they need to check the battery all the time. It's like when you're driving a car, you know that you have a lot of fuel, you don't really pay attention. But if you know that you're low on fuel, then you start paying attention and see, you know, and you try to realize how many kilometers you can drive. So in the natural history of each battery, unless you have a rechargeable system, but that's a different story. But in the natural history of the battery, you know that you have some time, and then over time, you know when you need to be a bit more careful and check the battery. We'll talk probably about other systems like rechargeable battery later on. But the second point I want to make, and which is the most important, yes, I said the patient and the family is part of the team, but this comes with responsibilities. I think we're far away from this paternalistic approach where the doctor knows everything and the patient is an object. You want to be part of the team? Fine, that's the way you do well with me and the type of care I provide. But you got to do something. And this something is lose weight, exercise, many things, follow the doctor's instruction, don't mess up with your medications. I can go on. And amongst the many things you need to do, if you really want to have the privilege to be a team member, is to check your own battery. So it's also time to really recognize that patients have something to do to help themselves and to help the doctors.
Amazing. Thank you. There seems to be a lot of comments in the chat. In this next question, it is very similar, and it revolves around patients who are living in smaller centers. So they may come to Toronto Western for the procedure, but then they have to go back home. So the question is, can DBS patients be confident that their local or regional hospital knows how to take care of them when things go wrong? In this question, they're specifically referring to infections, heart attacks, strokes, etc. But if there are risks, are we made aware of them, and what can we do about them as patients? Who would like to take that one?
Maybe I can take this one. I think I want to start. I don't want to take it too long. Don't want to make it too long. But historically, we've been much better, because when DBS started, and I'm now old enough to tell you that I've seen when it started, nobody knew about DBS. It was just 1, 2, 3 neurologists in the whole country. Now people at least hear about it, know what it is. They think, oh, it's a pacemaker for the brain. So I would say over time, also we teach this during residency and medical school. Often when they teach neurology, they also show patients with deep brain stimulation. So the overall education has improved greatly. And this is good to see. We have seen the difference over, past 10 years. So that's the positive. The negative is that it's true. There are many places where they might know what it is, but there's still some fear about it. And the problem, and this is once again the reason why I teach my patients, and they're part of the team once again, is that anything is then caused by DBS. I've seen in my life patients with heart attack going to a local emerge, and must be the DBS. So anything else is not real. It has to be DBS. And if it's not DBS, it must be Parkinson's, it must be dystonia, it must be tremor. And that's the real risk here. And what we're trying to do to bridge the gap is to create a network. I have a personal relationship with a lot of physicians in the community. We try to be collegial and to help them when they have questions. Sometimes we have questions. Can we do TENS? Can we, I'm a dentist. I'm following a patient of yours. Can I do this and this and that? It's not perfect, but I would say that things have improved a lot over time because the knowledge has increased. And just to finish on a practical note, patients need to know when they have a DBS device in their body, they need to go to any place, emerge, or when they travel, having their remote control with them. For many reasons, very practical reasons will be to turn the DBS off, to show them it's not DBS, or to have an ECG done without artifacts. They need to have their information that they have a DBS device in their body, what type, if it's compatible with MRI systems or not. And more importantly, the patient needs to tell the doctor, look, I know my disease, I know DBS. This has nothing to do with DBS. Please listen to me. So I found that often with the patient on board, knowing about what they have, what is in their body, they can actually teach the doctors they happen to meet. And this happens also with family doctors. Over time, the family doctor gets familiar because of what the patient tells them over time, not just reading these sterile notes that we send them.
Okay, thank you for that. The next question is about DBS and lifespan. I have an older DBS system installed. Do I get access to new DBS technology as it comes on stream if it would significantly improve my symptoms? Sunil, is that one for you?
Sure, I can take that one. So the good news is the space in the last, the hardware space, if you will, in the last 10 years has rapidly expanded, and there's competition, which is good because it means the companies are evolving the technology. Newer doesn't mean better. Our center is studying all the features. And so currently our current practice is we all meet once a month, all the team members here and other team members who aren't present here, and we discuss each patient that was seen by everybody. And we, in addition, as I mentioned, to choosing the best match for a target in the brain, we also choose what the best device and which features of a given device might be helpful for a patient and specific symptoms. So then we go forward with the surgery, and there's different companies, and even for a given company, there's different choices for electrodes and batteries. And the good news right now is that everything is back compatible. So generally, most of the new features that are coming out, there are ways to avoid changing the brain electrodes and taking advantage of the new technology at the level of the computer. Most of the useful features. There are some features that are not back compatible, and in that scenario, if there were a feature that that was important or that could change someone's quality of life, then we'd have to have a detailed discussion. At the current stage of technology, I would say we're not at a stage right now where we would make a recommendation to explant or remove someone's electrodes and replace them with new ones, because we have no evidence yet of any new feature currently available that's Health Canada approved that would substantially improve someone's results. But in the future, if that occurs, that would be like we would look at the case with a fresh set of eyes, and all of this is trying to minimize the risk, and there has to be benefit. And so we would look at the situation and see, okay, well, there is risk because we're redoing the entire operation again effectively once you're entering the brain. That is where the risks are low, but they're not zero. It's brain surgery, and so we have to be able to justify that the risk is appropriate for a sufficient gain in benefit. And when you move someone's leads or replace someone's leads, you can end up at a worse spot too, right? So you might have a better electrode, but an electrode that's not in a good spot is even though it's better is not going to be useful for someone. So that's an example of a risk. So we wouldn't just go in at this stage, and frankly, currently there's no new technology that would go against the old technology that we would make a recommendation as of today to swap out electrodes, for example, or change someone's system. Maybe in the future, but right now, that's not the case.
Okay, thank you very much for that. The next question, I'm going to actually merge the next couple of questions so we can quickly get to our live questions as well. Last week you spoke, I guess it's to Dr. Fasano. Excuse me, last week you spoke to a slide about DBS impacts on motor and psychosocial health and quality of life. So how can patients lock in the benefits of the DBS and lessen the hardest parts of the emotional and psychological impact of Parkinson's? And the following question is talks about the fact that DBS can apparently extend lifespan. So if you can sort of combine those two questions and talk about that.
Yeah, I can certainly talk to the second part of the question, but for the first part, it's a very difficult question. which actually triggered an email exchange that I had the following weeks after the first event with Dr. Zurowski. So I think it's also, she's more than me, is the right person to answer this question. But for the second part, I think we need to make a distinction between quantity of life and quality of life. Back in the days, even when there was no levodopa available, so when Parkinson's disease had no therapy, not even symptomatic therapy, the life expectancy of Parkinson's disease patients was on average 9 years, meaning that from diagnosis to death, on average, there were 9 years. With levodopa, the life expectancy has increased dramatically and is close to the life expectancy of someone without Parkinson's. With deep brain stimulation, we have further expanded the life expectancy. So people live basically very close or even identical to people without Parkinson's disease. I should also make a little note here that it looks like Parkinson's disease can also protect people from certain problems. It looks like certain cancer is less common in Parkinson's. Heart attacks are less common in Parkinson's. There are reasons to that. So I don't want people to believe, okay, Parkinson's are going to die earlier. No, there are, it's complex. We're talking about statistics. But certainly DBS has expanded the expansion initially seen with medications alone. So then the question arises, is this therapy that we're talking about, but even levodopa, just a symptomatic therapy, or we actually change the disease? And when it comes to dramatic improvement of symptoms, it's difficult sometimes to disentangle the effect on the symptoms versus the effect on the disease itself. Because as a matter of fact, the natural history has changed. People live longer. We now see people with Parkinson's for over 40 years sometimes, which is exceptional. If you talk to all neurologists, they will say, no, it's impossible. It was a wrong diagnosis. No, it's now possible. This is the quantity of life. The question is the quality of life. And this is where the psychosocial part comes in, because yes, you're alive, but you might be obese, on a wheelchair, forgetting stuff, not enjoying life, having hallucinations. There are many problems, and thankfully we're most of the time able to do something, but not all the times. And the adaptation part, which I was referring to the last time, it's a bit more complicated. And for that part, I prefer Matthias to answer. Sorry to give you the difficult one, but I think you have seen so many problems and so many positive stories in the end that you can have a better sense of what's happening to these people's life.
I get captured by the wording of the question, the locking in, because unfortunately this is an illness that you just can't lock in. I mean, it'd be great, and there is a stage almost that people are, they try and lock everything. They try and get up at the same time, eat at the same time, and take the medications at exactly the same time. Everything gets locked in. Everything is about Parkinson's. And if I do it right, everything's going to work right and I'm going to move right. And it maybe it works for a day or two, but something happens and then progressively something more happens. And DBS, what it does is it does give some uniformity. It definitely takes out that bottom dropping out for a lot of people. And yet there is still medications, there's still fluctuation, there's still this progression of illness that requires adaptation. And it is very hard. It is very hard dealing with an illness that is progressive, that has symptoms that are definitely more than motor. And really over time, motor symptoms become almost a footnote to this illness for many people, as there are cognitive changes, psychological changes that we can sometimes do something about for a time.
Okay, thank you very much, Matthias. I think we're now going to turn to some live questions, unless somebody else has one more thing.
To say something, please.
Sure.
I would just like to add that from my experience, Parkinson's is not a one-way street. You have better days, you have worse days. It's hard to predict, like Dr. Zurowski was saying. I had 3 fabulous days this week and 3 lousy ones that were very challenging, and I don't know why. But it's not all about going downhill. Sometimes you can have a great experience that improves things too. It's not all bad. There can be good things that happen along the way that are much better than you expect sometimes. like Ron is saying, thumbs up, life can be changeable, very good sometimes.
Ron, did you want to weigh in as well? You just have to unmute.
No, I think you guys captured it very well.
Okay, perfect. Thank you, everybody. We've got a lot of questions and not a lot of time left, so we're just going to make sure that we can get to some live questions. There are 3 questions in particular that have to do with personality changes. And so I'm going to start off with Harry Forstel's question to Dr. Surovsky, to Matthias. How well do we understand the psychological impacts of DBS? Does it intensify conditions that may already exist? And are those effects treatable? And maybe you can also, Matthias, touch on the fact that how often you notice personality changes and, and whether they're caused by the medication or the disease, if you can speak to that as well.
Harry, this was a very hot topic at one point about 10 years, 15 years ago, because it has been reported that partners would say that the person undergoing DBS, their personality is different. From the research that we subsequently did, it does seem like it is more to do with medication and dopamine, hyperdopaminergic states or low dopaminergic states. So people becoming almost manic-like with too much dopamine or apathetic with too little dopamine. As long as the electrodes are all in the right spot and everything else. That seems to be the issue, because that whole concept of a personality change, one of the difficulties has been the difficulty of nailing it down as to what exactly it means. But the quotes themselves and the experiences themselves did seem to suggest a dopamine story.
Annetta, is this something that you could weigh in on as well? You did mention a little bit about personality changes when it came to Ben's progression of disease.
Yeah, it seems like, so prior to DBS, I think his personality was fairly stable. The behaviors were fairly stable. His whole kind of interactions with others were stable, although they were very much dependent on what on and off, where in the on and off cycle he was, right? I mean, there are times when he would completely withdraw himself from any kind of social interactions and barely had, even when he, once he sort of came back to home or moved back with us, there were moments when kind of I needed to say, listen, I'm just checking in that everything's okay. And if you just need me to leave the house, leave your place or leave your space, I'm fine with that. I just needed to be reassured that you are still kind of doing okay on your own. So I think I think we've had some conversations with others kind of saying to us, well, but he's always been kind of impulsive. He always been kind of, the risk taker and this kid who's kind of couldn't find his own space very easily. And I would be very clear, no. Ben's personality, impulsivity, risk-taking was always there, but he was capable of being very calculated with it. He was really quite deliberate of when and where and how and when not to. So right after as soon as the programming started, I think it is, I think I have to agree with Mateusz. This was, in my opinion, and sort of my daughter-in-law is also a family physician, so she too kind of took some interest in terms of how we all respond to Ben when he's kind of up on some kind of a mountain and thinks that he's higher than everybody else. That was really dopamine. That sort of I always kind of looked at him and just my own professional experience from that lens when you're dealing with young people who are on drugs or who are struggling with addiction, kind of looking for the next fix all the time and kind of always being on the run and always never being able to sort of be in one spot. I kind of looked at that when when I was able to sort of calm down emotionally, kind of, and say, okay, what is it that I'm seeing? And I was seeing that kind of almost a substance induced behavior. What we have also learned that it was transient, that it was temporary. It could have, it wasn't a day or two. It could last up to a week, 10 days, 2 weeks, but eventually he kind of leveled off, calmed down, and having those conversations with him at that time were kind of up and down, because he really, well, who likes to be held accountable for their behaviors, right? And I think Dr. Fasano, you know him just as well. And who wants to have this conversation with their mother at the age of 37, right? And who wants to listen to his mother, and then who has this persistent mother who says, no, we're going to have this conversation right now because I can't deal with that otherwise. But that's a song and dance that every family kind of develops in how they deal with that. But I know that it has had a real a significant impact on, again, transitory as it is, on his relationship with some of people that he's very, very close with. Ron wanted to add to it. So that's my kind of.
Thank you, Annetta.
What I wanted to add was, before I had the DBS brain surgery, I was on a medication before levodopa that actually got me to eat. I mean, not to medicate. I gained like 30 or 40 pounds, and I'm not into sex, but I was looking at the websites, and I was so that was the medication. There are side effects to that as well. Before, it's all it was. They put me on the right medication, and everything went back to normal. So it's just something to keep here. I forget what the medication was, but it was before levodopa. So when it was medication, I got the side effects from.
Thank you, Ron.
I just wanted to add, Dr. Fasano, just wanted to add one thing. So just prior, the year and a half prior to this first, so since he came back from Cincinnati, May 9, 2020, till probably just before the surgery, Ben had lost a lot of weight, and his disconnect, he was so dyskinetic. He was exercising a lot, dyskinetic, eating quite a lot. I mean, this was a nonstop, constant, Mom, what's cooking right now? But still having lost quite a lot of weight. I think he probably lost in the last year and a half prior to the surgery about 20 pounds. Now, DBS happened, and Ben, within a very short period of time, gained a lot of weight. Literally, again, sort of some of those, my place of reference is the kids with substance abuse, constantly hungry and constantly looking for sweets, looking for some rewards that way. My whole family has issues with sweets, so that's a different story. But he was really very much into, I am hungry. I don't know. You have to understand. I'm hungry. I appreciate Dr. Fasano. You're telling him he needs to lose that weight because there are some significant health consequences that can happen. There's a family history of health problems with weight and heart problems and high blood pressure on both sides of the family. So he needs to be held accountable for that. But I think he's beginning to, the last I spoke to him a couple of days ago, he was for the first time kind of acknowledged that he's lost his way with that. So, but it is something that it kind of dovetails all of things that happened to him, or that the behaviors that we've seen. I don't know if that makes any sense, to anybody. Sorry, Dr. Fasano.
No, absolutely. I just wanted to add a little thing. Otherwise, people might be a little, things need to be clarified a little bit. So all we're talking about is an important concerns that sometimes people and families have are going to go for DBS. Oh my God, my personality is going to change. As you heard already, yes, there is a contribution of medications, but there is also a contribution of stimulation. Sometimes stimulation can make the difference. People might get irritable, impulsive because of stimulation. And this is when we need the family members, because obviously we don't live with the patient and we don't know the patient that well that you can say, okay, this is him, no, this is not him. But the good part of the story here is that it's everything reversible. So when it comes to personality, nothing is irreversible. And I think this is an important thing to recognize, and it's a trial and error. We monitor. And the last thing I want to say is that sometimes it's difficult for all of us, but also for what I do, to really understand whether what's happening is pathological or is just a simple reaction to the fact that you're doing better. Once I had a long conversation with a patient of mine that wanted to buy a boat all of a sudden. And I thought that, oh my God, this is stimulation. I'm making something wrong. And then the wife told me, no, this is his dream and he's finally able to move. And that's why I wanted to do it. So sometimes it's difficult to us understand what's normal happiness versus artificial happiness caused by stimulation. But with time, we can tell.
Interesting. Okay, thanks, Alfonso. The next question is about dystonia, and it's from Debbie Butler. I received DBS for dystonia in 2007, so that's 14 years ago. In the last year, I'm experiencing programming problems. Has anybody with over 10 years had problems too? With over 10 years, I guess since DBS, have they had problems too? Is this something that you've seen, Alfonso?
Yeah, because dystonia, exactly like all the diseases we're talking about, we're talking about syndromes. They are very heterogeneous conditions. And every disease is different, every person is different. But when it comes to dystonia, we're dealing with basically an umbrella term that involves so many different types of dystonias. Sometimes they are genetically determined. Sometimes we don't find a gene, but we know there is a gene somewhere. Sometimes it's a structural problem, like it happens with cerebral palsy. People with cerebral palsy might display dystonia. So it's hard sometimes to really understand why people don't do so well. Dystonia tends to also respond very slowly to DBS, and this might also jeopardize the ability we have to program the stimulation. There are other factors that have been studied because dystonia often is not that rewarding. One is electrode location. Sometimes the electrode, when they're not exactly placed in the right spot, might not provide the patient with enough benefit. And more importantly is the so-called skeletal deformities. So just imagine you have a torticollis for 20 years and then you do DBS. Yes, even if the muscles are not pulling anymore, at this point your bones are structurally different. And we can stimulate the brain as much as we want, but the bones, the ligaments, the tendons, the muscles, they won't change. So that's part of the problem. And we try to do DBS now earlier for dystonia for this particular reason.
Amazing. Is there anyone on the panel that wanted to weigh in? I think we'll move on. We've got time for one more quick question, and then we're going to wrap up this event, which has been amazing. Hope you've all enjoyed it and gotten a lot of incredible information. Oh, the question just disappeared. Hugh, to contact a doctor during a weekend or holiday is very difficult, but in the case of extreme emergency, how do you get help if it's life-threatening for DBS?
I can take that one. So life-threatening withdrawal is very rare with DBS. It's uncomfortable for most people to have a sudden withdrawal of the therapy, but in rare cases it can be life-threatening. So the advice is to attend your local emergency department. As Dr. Fasano said, bring your remote and your programmer. In that situation, the remote will tell you that the battery is no longer functioning. And your local emergency department, the emergency physician has a 1-800 number that can reach a neurosurgeon on call at the Toronto Western Hospital. And if it's if the situation is urgent, then we would bring you down to here. We like to do battery changes in a scheduled fashion. That's why I echo what Dr. Fasano was saying. You don't need to check your battery every day, but as you get closer to the time when you know your battery is going to run out, once we're within that window, we usually have about 90 days to schedule a change, and it's a smaller surgery. You come here in the morning generally, and you're leaving the hospital by lunchtime. If you're in a tricky spot though, and the battery goes out a few times a year, I'm here, and if it's a true emergency, I'll come here at 1 o'clock in the morning and change someone's battery in that rare case, because we know that situation, the longer it persists, there are actually true withdrawal symptoms that can be potentially life-threatening. It's very rare, but it is possible. So attend your local emergency department, have all your information, and the emergency doctor should be able to call. There's a 1-800 number where, as neurosurgeons, we cover a swath of the province, and you tell them you had your surgery at Toronto Western, if where your location or wherever in Canada you are right now, you tell them where you had the surgery, and they should be able to call the neurosurgeon on call for an expired IPG.
Okay, great advice. Thank you very much. Well, that wraps up the Q&A portion of our event tonight. I'd like to say a heartfelt thank you to our panelists and to all of our speakers tonight, and especially to Ron, Anne, and Annetta for sharing their personal stories. You can see in the chat that there's lots of comments and feedback on how important that was to hear from them. Thank you as well to everybody watching for making the time to attend and for your participation and asking questions. On a personal note, I've been fortunate to get to know many of you on the Patient Advisory Board through this event and others. And I have to say you're some of the bravest, most dedicated, and most inspirational started at the Krembil Brain Institute. So thank you to Gord, Hugh, Linda, and to Ben for your advocacy efforts and for always going that extra mile to help patients with Parkinson's and other movement disorders. And with that, I'm going to turn it back over to Gord for closing remarks. Thank you.
Wow, that was really great. I wanted to keep going. Did we mention that there's a loot bag coming? Will be sent to all the registrants. Anyway, it'll come. You'll see. Thank you so much for joining us for this webinar, and I hope that, as I know I have, you've learned a few things that will help you now and in the future as you make your way through your own movement disorder obstacle course. On behalf of the UHN MDC Patient Advisory Board, happy holidays, and stay tuned for our next event. Good night.